Hi, Dr. Nidini.
Dr. Nidhi hai.
Sir, hai.
Hello everyone. Hello
Good morning,
everyone.
sir.
Welcome.
Hello, good
Welcome.
morning. Usually you give your first this COVID condition.
We are live. So everyone, welcome to our weekly Sunday meet. So today we're going to be talking about sickle cell anemia. It's been on the 19th of June was sickle cell anemia day, and we are bound to spread awareness about the same. So we have with us Dr. Arora, who is the General Secretary of the National Thalassemia Society, and he'll be giving us the lecture about sickle cell anemia and throwing some more light about this rare albeit common condition. So without much ado, I would hand it over to Dr. Arora.
Thank you, Dr. Meenakshi and Dr. Nidhi and FCFI for giving me once more chance to speak on the topic which is by close to me, the thalassemia and sickle cell anemia. Can you see my slides? My slides are visible?
Yes, sir. Yes, sir.
Okay. Just a minute. How we can hide? Okay. So good morning. See, on this, Dr. Meenakshi told you 19th June was a sickle cell day. So today I'll be speaking on the sickle cell. Though it is not very common in North India, but still quite oftenly we see cases from this who are migrated from this other parts of India, which is tribal area. So we do get these cases, so that's I'm here to discuss. I'll just give the overview of the sickle cell disease. It is an it is a disease of abnormal hemoglobin, that is sickle hemoglobin. There is a genetic defect in the beta globin chain, that there is substitution of valine for glutamic acid at 6th position of the beta globin chain. When deoxygenated, the red cells undergo sickling due to polymerization of the HbS. After recurrent episodes of sickle cell sickling, membrane damage occurs. Cells not capable of dissolving biconcave shape upon reoxygenation, and deformed sickle cell adhere to endothelium and macrophages, induces hemolysis. See here you see these are the normal red blood cells, but they can change the shape and they pass to microcirculation, but they come back to normal shape. While in sickle cell, then they, because of the this polymerization, they form the sickle shape. Sickle cell syndrome can divide into 3 parts. That is heterozygous state, where the HbS is less than 40%. It is sickle cell trait or carrier state. Homozygous, when the hemoglobin S, that is sickle hemoglobin, is more than 80%. That is sickle cell anemia. This is a full form of the disease. Double heterozygous may be one sickle cell disease plus either beta thalassemia, C or D, or some other variants. Normal red blood cells are biconcave, disc-shaped. They are deformable, means they can change the shape according to the vascular condition when they pass through microcirculation. Lifespan is around 120 days. In sickle, they are sickle shaped, rigid, and lifespan of the sickle cells is less than 20 days. That their surface is sticky. Here you can see in peripheral sphere, you see the sickle cell in the peripheral sphere. How to diagnose sickle cell? So it's a very simple test, sickle solubility test. This is a mixture of HbS in a reducing solution, that is sodium bisulfite. It gives a turbid appearance, and that is precipitation of HbS. Here you see it is the normal blood, which is not HbS. That is normal hemoglobin gives a clear solution. What we do is we pass this sodium metabisulfate solution in the test tube. If we see beyond that there is a line of paper, if it is transparent, that is normal, and if it is opaque, then it is having sickle hemoglobin in that blood. While confirmation of diagnosis is done by the HPLC, Here you see that newborn screen, we have seen the HPS very high, some amount of fetal hemoglobin is there, that is homozygous. While here you see HPA and HBS both are there, that is heterozygous. When A is more than S, that is sickle cell trait or sickle alpha thalassemia. When there is only S and F and no A, it may be sickle cell anemia, that is homozygous, or sickle plus beta 0. If sickle is more than A and there is some F, it is sickle beta, maybe sickle beta plus. So in sickle cell, we see the hemoglobin about 5 to 10 gram, PCV 15 to 30%. TLC is mildly raised, platelets are raised. In peripheral sphere, you see anisopoikilocytosis, sickle cells and target cells. Reticulocytosis 5 to 20%. Serum haptoglobin is reduced. Urinary urobilin is increased. ESR low. Iron, you see increased iron, ferritin, and transferrin. Mostly it is because during anemia, we people give iron to these people, these patients. This is how it is passed from parents to children, just like thalassemia we have seen, because it is a recessive autosomal recessive disorder. If both parents are sickle cell carriers, then in each pregnancy, you see 25% chance of having a normal child, 50% sickle trait like parents, and 25% homozygous sickle who is a diseased person. Sickle patients have natural protection from malaria because the patient with HPS are relatively protected from against malaria falciparum specifically. Plasmodium, when infected RBCs, it induces quicker sickling. The sickled RBC with parasite inside them are sequestered in spleen and thus providing protection because they die quite early. They don't give full symptoms of malaria. That is why in world over we see sickle is more common where malaria is more common, or you can say earlier it is Africa, Middle East, and Asian countries. The sickle map overlaps the malaria map. This is another hypothesis that the sickle have protection against malaria. Even in India, it is more common where malaria is very common. It is mostly in the tribal communities. It is up to 5 to 40% found in some tribal communities. 10,000 plus infants are born sickle cell every year. It is considered to be mild and anemia in India. In Africa, it is very severe. Even in Middle East, it is severe. While in Asian countries, especially in India, it is not very severe. That is another reason why we don't frequently see sickle cell and mostly go undiagnosed. This is a reason that the ICMR survey showed that 30% of diseased children among the tribal community die before they reach the adulthood. It is not found in North India, Andaman Islands, some quantity in Bihar and Jharkhand, but highly prevalent in Odisha, Madhya Pradesh, Tamil Nadu, Gujarat, Kerala, Maharashtra, and Rajasthan. This is another map of India where you see in Gujarat up to 30%, Madhya Pradesh, that includes Chhattisgarh with old map, and same here Odisha, Maharashtra 33%, Andhra, Telangana up to 34%, Karnataka, Tamil Nadu, but very few in Bengal and Bihar, Jharkhand. But we have seen many cases in Assam now as well. That's the reason because the most of the laborers migrated from this Madhya Pradesh and Jharkhand to Assam. So we are seeing very frequently in Assam as well. Sickle hemoglobin is prone to polarization with other hemoglobin molecules under low oxygen tension, and due to deformed shape, HPS damages RBC membrane, leading to calcium influx into the cell. That calcium influx leads to cross-linking of the membrane proteins and that allow afflux of potassium and water from the cell. This leads to RBC dehydration, exacerbating the sickling. And vaso-occlusive crisis results from the sickled red cell obstructing and reducing blood flow to vital organs, leading to ischemia, necrosis, and pain. So this is a pathophysiology of hemolysis and vaso-occlusion in the sickle cell anemia. Red cells containing HBS, when they pass through microcirculation of spleen, because of low oxygen tension, sickling occurs. But again, when these cells pass through circulation where there is a good oxygen, that is other organs, they are de-sickling occurs. Various cycles of sickling and de-sickling that leads to loss of cell membrane and change in membrane permeability. Then and ultimately irreversible sickling occurs. So what are the factors that affect the degree of sickling? The first and foremost is, as I told you, amount of HbS and interaction with other hemoglobin chains. In heterozygous, where the HbS is less than 40%, it occurs only when there is hypoxia. Usually we see when these people go to mountains. That is the reason they are they should be cautious when they are on flight as well, or when they go to hilly areas. And in the homozygous state, when it is more than 80% HbS, it is a full-blown sickle cell anemia disease case. In fetal hemoglobin, it inhibits the polymerization of HbS. Hence, newborns do not manifest the disease until they attain 5 to 6 months of age, because when a child is born, it is having more than 80% of fetal hemoglobin. And that is why there are some medicines which are used to increase HbF to decrease the manifestations of the sickle cell. HBC, which is usually not very common in India, but it fight mutation in beta globin at 6th position, substitution of lysine for glutamic acid. It has a greater tendency to form aggregates with deoxygenated HbS than HbA. So HbSC is more severe than even sickle beta thalassemia. Rate of HbS polymerization is strongly dependent upon the Hb concentration per cell MCHC. Intracellular dehydration leads to increased MCHC, and that leads to increased sickling. When there is sickle alpha thalassemia, that reduces globin synthesis, and so there is decreased MCHC and disease is milder. So sickle alpha is a milder disease. When there is a decrease in pH, it decreases oxygen affinity of hemoglobin, thus increases sickling. The length of time the RBCs are exposed to oxygen also matters for the sickling. Sickling of red cell is confined to microvascular blood cells. That's where blood flow is sluggish. For example, in spleen and bone marrow. Inflammation and increased red cell adhesion also increases the transition of blood from the microcirculation. So that is a longer red cell transit time that also leads to sickling. Clinical symptom, the sickle cell trait, that is heterozygous AS condition, which is mild, may remain undetected. Sickle cell anemia is homozygous, as just said, you can see the symptoms by 3 to 12 months of age, and mostly these are splenomegaly, growth retardation, hand and foot syndrome, leg ulcers, abdominal pain, infections, gallstones, cerebrovascular symptom, etc. And if there is any double heterozygous like beta, C, D, E, or Q, then the symptoms depend upon the condition. If it is beta plus, the symptoms are mild, beta 0, symptoms are severe, same it is severe with the C and D. If you remember, I told you with the A with the beta thalassemia with D is not severe, but sickle with D is very severe. You see the parameters in HbS, this homozygous stage is 70 to 90%, in heterozygous 25-40%. Fetal hemoglobin is 10 to 30% homozygous, while it is less than 1% in heterozygous. A is nil, in heterozygous 60 to 75%. In homozygous, they are very pallor is very high, but in heterozygous may or may not be. Jaundice in homozygous, splenomegaly and hand-foot syndrome are seen in the homozygous only, not in the heterozygous. Leg ulcer and vasoacalism again in homozygous. Hemoglobin 5 to 7 in homozygous, while in 10 to 13% in sickle cell trait. That is why we may not diagnose sickle trait normally. Sickling test, which I told is positive in 30 minutes in homozygous and positive in 4 hours in heterozygous. On electrophoresis, if you see HBS and HBF in homozygous, while in heterozygous HBS and HBA. Reticulocytes are increased in HBSS while normal in trait. An acute illness characterized by, this is the pathology, an acute illness characterized by the exacerbation of clinical features of SCD such as pain, anemia, or jaundice. Deoxygenated HBS molecule polymerizes, which is unstable and causes erythrocyte damage. Polymerase cells infect the leukocytes and platelets, leading to occlusion of blood flow. Microvascular ischemia infarction leads to stasis, congestion, and organomegaly of liver and spleen. This process continues to atrophy of organs, especially spleen. We see spleen atrophied after 2 years or 3 years. There's a progressive infarction, cell death, and fibrosis. So these are 2 primary manifestations of sickle cell disease, that is hemolysis and vasoocclusion. Anemia in sickle cell is caused by red cell destruction or hemolysis, and degree of anemia varies widely in between patients. Red cell production by the bone marrow increases dramatically, but it is unable to keep pace with the destruction. So as much as it is destroyed, but they are not produced. Vasoocclusion is initiated by rigid and abnormally shaped sickle RBCs. Abnormal adhesion occurs to the endothelium. Activation of WBC in the RBCs and the endothelial surface enhances vasoocclusion crisis. This results in tissue damage, hypoxia, necrosis, and organ dysfunction. What are the acute manifestations? They are because of bacterial sepsis or meningitis, recurrent vasoocclusive pain, dactylitis, that is hand-foot syndrome, musculoskeletal or abdominal pain. Splenic sequestration occurs because of trapped RBCs in the spleen, aplastic crisis, acute chest syndrome, stroke, priapism, hematuria, including papillary necrosis. The chronic manifestations are anemia and jaundice, splenomegaly followed by functional asthenia, cardiomegaly and functional murmurs, hyperthyroidism and angiosis, proteinuria, polylithiasis, delayed growth and sexual maturation. There is restrictive lung disease, pulmonary hypertension, avascular necrosis, proliferative retinopathy, leg ulcers, and transfusion hemocytosis. And those are mentioned in bold and star. They are more subtle. So what are the challenges and crises in the sickle cell disease? Vasoocclusion, this obstruction of microcirculation due to intravascular sickling. Hand and foot syndrome occurs between 2 to 3 years of age, or less than that even. And bone and joint crisis after 3 years, mostly large bones, spine and rib cage. Infarcts of mesentery and abdominal viscera causes abdominal pain, which is very severe, but it lasts for 4 to 5 days. Strokes are very high if the fetal hemoglobin is less than 8%. These are 2 types. While in the younger age, there is infarct like occlusion, 2 to 15 years, while it is hemorrhagic in the older cases. Acute chest syndrome is because of infections and increased sickling, and it is a microvascular thrombotic disease. Then, because of hematologic crisis, there is sudden severe anemia. If untreated, it will lead to death. Aplastic crisis occurs because of parvovirus B19. It reduces hemoglobin, but in a normal person, what happens is 30 to 40% reduction in hemoglobin. But we people don't face any problem. While in these cases, they have severe anemia, but still it is self-limited and recovery is between 5 to 10 days. Splenic sequestration occurs between 4 months to 24 months. If there is reduced HbF, it is very severe. Hypovolemic shock occurs and it may lead to death. Hemolysis may lead to increased lipid peroxidation of sickle cell. Megaloblastic anemia occurs because of sudden arrest of erythropoiesis by the folate deletion. Their infections are very common in sickle cell pneumonia, meningitis, infection, osteomyelitis. That is the reason they are, though this now pneumonia vaccine has been made mandatory, but they are specially given repeatedly after 3 years, every 3 years. So what are the triggering factors to cause sickle cell crisis? These are infections, extensive trauma or injury, hypoxia. That is why they should avoid the area where there is less oxygen going to hilly areas. Exposure to cold. During winter, they have more sickle cell crisis. Dehydration. That's the reason they are told to take plenty of water. Always keep hydrated. Physical exertion. They are also advised to don't take physical exertion too much. Acidosis, psychological stress, and malaria may cause acute hemolysis and it may lead to hyperhemolysis. So because of acute ischemia, there are pain episodes and stroke due to damage and occlusion circle of Willis. It is highest during the age of 2 to 5 years. Priapism, acute chest syndrome, splenic infection, splenic dysfunction from 3 to 4 months, and it becomes non-functional by 3 to 4 years. Infection due to functional asplenia. That is why they are giving pencil prophylaxis start from 3 months to 5 years of age. The chronic damage are in the lungs. It is pulmonary hypertension from 20 to 30 years. In kidney, it may cause hypersterolia, that is low specific creatinine urine. Vasocclusion of the blood vessels in the renal medulla, renal papillary necrosis, and they have recurrent cholelithiasis from 2 years of age. In eyes, they have proliferative retinopathy, hemorrhage, and damage to macula and leading to blindness. Joint pains by 3 to 4 years of age. Hip and shoulder joints are mostly involved. Occasionally, knee and ankles as well. Hip necrosis is very common in the sickle cell patients. It involves every organ. See, it may lead to retinopathy, and if there is a cardiomegaly, then the congestive heart failure, cholelithiasis, if renal infarct, because it may lead to hematuria, bone marrow hyperplasia, osteomyelitis may occur because of aseptic bone necrosis, cerebral infarct and stroke may lead to mental retardation, pulmonary infarct may lead to pneumonia, splenomegaly may lead to splenic atrophy, that is autosplenotomy, infarcts of extremities, that is, I told you, there's a hand and foot syndrome, vaso-occlusion, and leg ulcers. The clinical markers of phenotype heterogeneity are dactylitis, pain episodes, stroke by 10 years, and stroke 10% by 20 years of age, and by 45 years, 25% of sickle cell patients have stroke. Acute chest syndrome is most fatal, and if it is frequent, that is mostly they die between 3 to 4 years. Cholelithiasis, pulmonary hypertension, very frequent. And in adults, it is 25 to 40% and death within 4 years. Priapism, osteonecrosis, and proliferative retinopathy. What are the laboratory markers? If HB level is at steady state, it is not very severe. High hemoglobin causes less sickling, so their longer cell survival, less anemia, less complication, and they live longer. LDL directly correlates with the pulmonary hypertension. Free HB in the circulation. That free HB is because of the hemolysis of the red blood cells, and it reduces the nitric oxide. That reduces the ability to vasodilate and increases pulmonary hypertension. Brain MRI and MRI should be done from 2 years of age. In 25% patients by 2 to 16 years, they develop silent stroke, and they have impaired neurotask. Transcranial Doppler, the rate of blood flow to it is done by from 2 years of age. If it is less than 170, it is normal. If it is 170 to 200, it is you can say borderline, and if it is 200, it is very severe. So sickle cell double S, that is homozygous, which is very severe. You see S is more, Hep and A2 are less. Sickle cell SC, S and C are more, F and A2 balance is moderate to severe, S beta 0 is severe, S beta plus is mild, S beta delta beta is also mild. The risk factors below 2 years of age and dactylitis in less than 2 years, less than 1 year old, have severe disease by 10 years. If the patient developed dactylitis, hand-foot syndrome in the first year of age, then the child is going to be having severe disease by 10 years of age. And WBC count at between 12 to 24 months, if it is very high, and neutrophils are more severe than disease by 10 years of age. If hemoglobin level by second year of life is less than 7 gram per deciliter, then the disease is going to be more severe. Early dactylitis and severe anemia, if it is, then disease will be severe. If there is severe anemia but no dactylitis, then it will be not very severe but severe. Early dactylitis but no severe anemia, it will be moderate. If no early dactylitis or severe anemia, it will be mild. And if it is severe, then we start the transfusion therapy much earlier. And effect of anemia on the clinical course. If there is anemia, there is more mortality, leg ulcers is high, stroke, silent infarct, and in pregnant ladies, small for gestational age babies. Pre-operative transfusion are given to lower the rate of sickle cell disease related to post-operative complications. See, whenever there is any surgery, they are specifically given this blood transfusion to avoid complications during and post-surgery. Prevention of crisis. As I told you, what are the factors which trigger? So we have to avoid the infection. As soon as the fever starts paracetamol or cold fermentation, there should not be any dehydration. Avoid acidosis. If there is you can say hypoxemia, that should be oxygen should be given. Cold exposure should be avoided. Exhaustion, they should be not advised to have exert severely. Avoid high altitude. And pneumonia vaccination in less than 2 years, booster after 3 years. H influenza vaccination, hepatitis B, penicillin prophylaxis from 4 months to 5 years. Folate supplementation, splenectomy whenever advised. Analgesic, paracetamol is the best one because they have to take analgesic very frequently. So NSAIDs, others should be avoided. That may cause to gastric and liver problem, gastric, liver, and nephrotoxic maybe. Avoid weight bearing in early phase of necrosis because I told you they develop this hip necrosis very frequently. So they may cause fracture of the hip bone or even the head of the femur. So how to manage? Make the patient comfortable, give effective analgesia. Mostly when their patient is going to the hospital, they are giving this morphine or pathedic. Then in the usual analgesic don't work. Give oxygen if the this SiO2 is less than 92%. Optimal oral rehydration. Balance between renal shutdown and pulmonary edema. Dextrose when required. Antibiotics. Hydroxyurea is very effective in this sickle cell patient. Usually it is given as a preventive measure as well. Blood transfusion is given when there is signs of anemia or absolute reticulum is less than 100 10⁹, and there is a fall of more than 2 grams of hemoglobin. Hydroxyurea decreases hemolysis and amyloid symptoms. High baseline F reticulocyte increases HbA by 10 to 18%. So hydroxyurea increases fetal hemoglobin. Dose is 15 to 20 milligram per kg per day. And usually we start with 10 milligram and go to 25. But in some patients, we have tried up to 30 as well. And that is experience of giving for long term, even up to 25 to 30 years of life. Strict monitoring with CBC because hydroxyurea may cause pancytopenia. So it should be every 3 to 4 CBC should be done. And if it is TLC is less than 3,000 or neutrophil less than 1,000 or platelet less than 1 lakh, so hydroxyurea may be stopped for a short time and maybe restarted with a low dose. So to treat the leg ulcer is very common in this sickle cell anemia. the bed rest, elevation of conducted extremities, wet to dry dressing, systemic antibiotics, Ona boots. These are the low compression gauze bandages containing zinc, gelatin, glycerin water. See, in this leg ulcer, what we do is we keep the inner portion wet, either with Vaseline dressing or, as I told you, this any gelatin, glycerin, etc. And then 2 or 3 layers are given, and outer layer is the driver. Blood transfusion is given to reduce the HbS to 40%. If leg ulcer is not healing, then we go for blood transfusion as well. Skin grafting may be required, and zinc also helps the healing. Routinely, blood transfusions are not required, especially in the Indian sickle cell patients. It is usually given only when the anemia is less than 5 gram or splenomegaly, or there is any progressive organ damage. Especially surgery it is given, and pregnancy, third trimester, to avoid vasoconstriction. But blood transfusion has its own challenges. It may lead to infection like hepatitis B, C, HIV, and allomenism is very common. See, if you don't, as I told you in the thalassemia as well, in thalassemia major, we start this blood transfusion by within 1 year or 2 years of age. Then they don't cause allomenism. While in thalassemia intermedia, anti-DT, we start later and we see allomenism. The same way in sickle cell, since there's blood transfusion is not given daily in early age, so it may cause allomenism. And repeated blood transfusion leads to iron overload, that is hemocentrosis. So what are the indications of chronic transfusion? To prevent a recurrent stroke, as I told you, the stroke may occur even from 2 years of age. If we see this transcranial Doppler more than 200, then we should start transfusion. If it is less than 170, you may avoid it, but between 170 to 200, it may be considered depending the case to case. Recurrent severe acute chest syndrome should also be given. There's a blood transfusion. Chronic hypoxic lung disease, chronic debilitating pain episodes. If you are having repeatedly pain episodes, then also give blood transfusion. Severe anemia of renal failure, chronic heart failure. There are additional benefits of chronic transfusion are it reduces hospitalization, pain episodes, acute chest syndrome, infections, and it improves growth and well-being. Glutamine has been tried in sickle cell patients. It reduces oxygen damage to RBCs by improving the redox potential of nicotinamide adenine dinucleotide. It's a coenzyme primary regulator of the oxidation. It reduced the frequency of sickle cell crisis by 25% and hospitalization by 33%. Decrease in cumulative hospital stay days by 41% and lower incidence of acute chest syndrome by more than 60%. And common adverse reactions noticed are constipation, nausea, headache, abdominal pain, cough, pain in extremity, back pain, and chest pain, which is non-chronic. Role of P-selectin in sickle cell crisis. In the chronic pro-inflammatory state in sickle cell, P-selectin is upregulated and overexposed. P-selectin is key player in the multicellular adhesion involved in vaso-occlusion and crisis. Blocking P-selectin in function may prevent vaso-occlusion and improve blood flow. Humanized monoclonal antibody, that is crizanlizumab, binds P-selectin with the high affinity and specificity, blocking its ability to bind to its receptor. Long-term administration of a P-selectin blocking agent, that is crizanlizumab, has the potential to improve blood flow and avoid acute vaso-occlusive crisis in the patient with sickle cell disease. So finally, what's the conclusion? The early diagnosis, that is why the neonatal screening has been started. It is done long back in Europe, Africa, and America. And now in India, it has also started neonatal screening of the sickle cell disease. Two sicklers don't behave similar. That is very important, that even if they have same genotype. So that is why this treatment of the sickle is very much individualized. Multi-genetic and environmental factors decide, as I told you, this cold atmosphere. If they are living in cold areas, they may shift to this warm areas, or say high altitude, or you can say if there is a breeze, is tej hawa chal rahi hai, that it should be avoided. So assessment of clinical laboratory markers that I told you earlier, that help us in whether we should start blood transfusion, because with blood transfusion, the life is absolutely normal, excluding some other complications resulting of infections or this iron overload. Hydration is very important. So that is why we again and again, if you say the tips of the this sickle cell treatment are, that is hydration, avoid you can say cold exposure, avoid exhaustion, give prophylaxis, vaccination, and you can say hydroxyurea. These are the primary things. And parents should be educated how to you can say diagnose the condition, not the sickle cell, but you can say what are the crises, how to manage that. That is usually educated parents are educated how to deal with the condition that the patient is going to face. And the most important is, as I told you, the thalassemia, sickle cell disease is preventable. If we check sickle cell condition before marriage and sickle cell trait, and either prevent the marriage or diagnose during fetal early pregnancy, then we can prevent the sickle cell disease. Thank you.
Sir, excellent talk as always.
Thank you, Dr.
Sir, मैं ये देख रही थी.
It's all your, you can say, because of you, because I see you are doing a lot of things. Let me do something that.
Yes. Sir, but congratulations, because I was just waiting for this to cross 100. 92. I've been watching the number of participants, so definitely 93. I'm hoping that we will cross 100 today. 92, and I think there are, yes, abhi aap 96.
नहीं, अभी तो और बहुत आ रहे थे, मैंने एडमिट नहीं किया आपने देखा.
Anyway, sir, so when we see somebody in the OPD, तो आपका पहला क्या रहता है कि this alerts you to it being sickle cell? That's one.
But means I mean to say how to diagnose in the OPD. You mean to say?
What is a red flag for you कि मेरे को इसको तो investigate करना ही है for sickle cell?
See, especially most of the one thing is I told you very good, that is it is not very severe in India. ये एक बहुत अच्छी बात है. So that is the reason कई बार miss हो जाता है. So early signs are, if you are seeing especially that this child is not going well and having repeated pain episodes, that's the first sign you see. Pain episodes or even repeated infections. So if you go for this this CBC count, and even there you will see that the same parameters that we have seen in the thalassemia as well. So and then you can also advise HPLC. Pain episode is the most common that you will see.
And sir, when you do diagnose, as you said, the important thing is stay hydrated, avoid exhaustion, avoid extremes of temperature. Those are of course there. Are there any medicines specifically that you would say are contraindicated in these people?
Not very, but only to see they require this painkillers very frequently. That is why we give them either paracetamol or you can say morphine pethidine based drugs. But usually now they have been even advised to take at home as well.
Okay.
By a specialist under you can say this strict monitoring. Hydroxyurea, if hydroxyurea is a one medicine. See, अगर आपको कोई पेशेंट आता है ना, कुछ नहीं करना हो, सिर्फ उसको यही बोलना है कि ठंडे से बचना है, मतलब ठंडे पानी में नहीं जाना, ठंडी हवा में नहीं जाना, कीप योरसेल्फ वार्म, हाइड्रेशन रखना है, दैट इज मोस्ट इंपॉर्टेंट, हाई एल्टीट्यूड नहीं जाना, and the most common drug which is easy to be used and quite safe and have been used for over 30 years, that is hydroxyurea.
Okay, sir. I don't see any questions in the chat box. Any specific contraindications to hydroxyurea?
I told you cytopenia, that's all, nothing else. You have to see that, monitor that CBC count.
So, sir, जैसे डॉक्टर के और डॉक्टर मीनाक्षी दोनों ही कहते हैं, या तो सब कुछ समझ आ गया या बिल्कुल
बिल्कुल ठीक, आपने कहा बिल्कुल सही बोला है, बिल्कुल यू आर राइट, या तो सबको समझ आया है, कुछ समझ नहीं आया. Actually sickle is not so common in North India ना, तो that is also reason, क्योंकि जब पेशेंट देखते ही नहीं है और यूजुअली उसको पढ़ते भी नहीं है तो फिर क्वेश्चन भी दिमाग में कम आएंगे. That is also true. So we are one way very lucky कि in India it is very mild one.
Unlike thalassemia, which in India is pretty common.
Yes. नहीं, it is common. It is very common. अगर आप ट्राइबल एरिया में जाओगे आपको हर घर में मिलेगा.
अच्छा.
हाँ, तो बल्कि वहां में एक चीज आपको बताऊं, कई बार आपने देखा हो, यू विल सी द चिल्ड्रन, उनके आप इवन बड़े भी होंगे, उनके पेट पे ना वो एक बर्न का निशान होगा. यू नो व्हाट दे डू इट, वो स्प्लीनोमेगाली होती है, वो कहते हैं ये इसको जलाने से स्प्लीन ठीक हो जाता है. मतलब ये हाइपोथेसिस. तो उनको आपको ये मिलेगा. तो मतलब ट्राइबल एरिया में सिकल इज वेरी कॉमन, बट क्योंकि बहुत ज्यादा सीवियर नहीं है तो इसलिए थोड़ी सी कम देखने को मिलता है.
I believe Madhya Pradesh में also it's quite common.
हाँ, वही तो मैं कह रहा हूँ ना, मतलब see, it is highest in Madhya Pradesh, Chhattisgarh, Gujarat, Odisha, Karnataka. It is very high. North India में नहीं है, हमारे अपना Punjab.
Because I have families there and they are very well aware of sickle cell. The families that I have in Madhya Pradesh.
Yes. It's a common. Madhya Pradesh, Chhattisgarh is very common, and Jharkhand, Odisha, wherever there is a tribal area, it is very common.
Somebody called RSN has written, to maintain HB, which drug should be administered to someone who is just diagnosed with sickle cell disease?
I told you the simplest and the easy drug is hydroxyurea. And even if you are having a still repeated complication, usually we start transfusion, especially if you are anticipating this acute chest syndrome or stroke, because we cannot, we can say, wait for the stroke to happen. If at all, even a single stroke happens, then you must start. And if you can do transcranial Doppler, then if it is more than 200, you must start this transfusion therapy. And repeated ACS, that is acute chest syndrome. See, it depends. The transfusion is given depending upon the condition of the patient. In thalassemia, we give regularly. In thalassemia, it is different. But in sickle, we give only when it is required. When they have some complications which are not treatable with the preventive measures or hydroxyurea.
Thank you, sir, for answering these questions. I don't think there are any more questions at the moment. But I think if there's anything, when is splenectomy indicated in sickle cell disease?
Splenectomy is indicated when there is usually when there is splenic sequestration. Means that is an emergency. वो एकदम जो आपका blood आता है, that is trapped in the spleen, वो इतना बड़ा हो जाता है, that is hypovolemic shock. means सारा blood spleen में जाता है, बाहर जो आपके peripheral vessels में blood नहीं होता. That is a one condition in acute case that you require splenectomy. And second is if there is splenomegaly, then you go for, or hypersplenism, or you are having this cytopenia because of hypersplenism, then we go for splenectomy.
Okay. So I think those are all the questions today. Sorry, there was some technical glitch today because of which we could not admit some people in the first 10 to 15 minutes. So we're sorry about that, but it is the entire episode is telecasted on Facebook and YouTube. So you can probably see that whenever you have the free time. I must thank Dr. Arora for doing these pertinent topics. It is it is Blood Awareness Month, Blood Disorders Awareness Month in June, and we are very happy that we could have 2 sessions by Dr. Arora. And sickle cell anemia, जैसे मैंने बताया था, it's rare albeit common. So of course we don't in Delhi and maybe in northern India in our OPDs probably we don't see these diseases, but it's always good to revise all these topics. Because if it is there, it can cause serious problems to the patients. So a big thank you to Dr. Arora, and a big thank you to the large numbers gathered here. We'll keep doing this. We'll talk about maybe COVID next week. Thank you everyone for joining in. We'll see you again. Bye.
Okay. Thank you.
Thank you so much, Dr. Arora. Thank you.
Thank you, Doctor. Thank you, Dr. Nidhi and Dr. Nakshi.